The technique for the Onlay dynamic anterior stabilization augmented by the Sachs Remplis is presented in this video. The diagnostic arthroscopy starts with the patient in the beach chair position and the shoulder placed in 70 degrees of forward flexion, with the posterior viewing portal placed immediately under and 2 cm medial to the posterolateral edge of the acromion and an anterior working cannula placed in the rotator interval. The lesions are dynamically inspected looking from posterior in the right shoulder of a patient with a slab type 2 tear and an off-track bipolar lesion with 16% of anterior glenoid bone loss, 22 mm of Sachs interval, and a glenoid track of 20 mm. The posterolateral percutaneous portal for the Sachs Remplis is established from outside in under direct articular view, and the anchor is implanted at the lateral edge of the Sachs lesion to avoid loss of external rotation while providing a posterior restraint to anterior dislocation. The 4 suture limbs are retrieved with the suture passer piercing through the infraspinatus and posterior capsule in a parachute configuration and are left reference for later tying of the 2 mattress knots. The anterolateral portal is established from outside in over the LHB tendon, and the radiofrequency ablator is used to clean the rotator interval. And it is used to mark the placement of the 4 o'clock and the 5 o'clock anchors, excise the MGA gel, and safely split the subscapularis tendon between the upper third and the lower 2/3, cutting from deep to superficial. Once the subscapularis tendon split is established, the anterior cannula can be introduced through it. The drill guide is placed through the subscapularis tendon split and the 5 o'clock anchor is implanted first. The all-suture anchor is armed by pulling against the cortical bone, and the same colored suture limbs are pulled to check that the sliding mechanism of the anchor is working. A 16-gauge spinal needle is loaded with 1 wire with eyelets and introduced through the anterolateral portal. The needle is used to pierce the LHB tendon distally and posteriorly. The wire is retrieved through the anterior portal using a grasper, and the eyelet of the wire is loaded with one of the blue suture limbs of the 5 o'clock anchor and is shuttled through the LHB and out the anterolateral portal. The white suture limb is passed through the LHB tendon in the same way, and the first double pulley knot is thus tied between the blue and white suture limbs of the 5 o'clock anchor. The 2 opposing white and blue suture limbs are pulled from the anterior cannula until the first double pulley knot sits on top of the LHB. The spinal needle is loaded with the wire and used in the same fashion as shown before to pass each of the remaining 2 opposing limbs of suture of the 5 o'clock anchor through the LHB, this time more proximally to the first double pulley knot. Care is taken to reference the 2 suture limbs of the 5 o'clock anchor that are left parked out of the anterolateral portal. The drill guide is placed again through the subscapularis tendon split, and the 4 o'clock anchor is implanted second. The all-suture anchor is armed by pulling against the cortical bone, and the same colored suture limbs are pulled to check that the sliding mechanism of the anchor is working. 16-gauge spinal needle loaded with wire with eyelets is used to pierce the LHB tendon more proximal to shuttle 1 blue and 1 white suture limb of the 4 o'clock anchor to tie the second double pulley knot in the same fashion as the first one. Each of the remaining 2 opposing limbs of suture of the 4 o'clock anchor are passed through the LHB, this time more proximally to the second double pulley knot. The 2 opposing suture limbs of the 4 o'clock anchor are parked in the anterior portal and referenced with a hemostat clamp, and the 2 opposing suture limbs of the 5 o'clock anchor are parked in the anterior portal and referenced with a cocker clamp. Looking from the posterior portal, the arthroscope is pushed forward anterolaterally under the LHB and directed towards the bicipital groove. The radiofrequency ablator is introduced through the anterolateral portal and used to cut the transverse humeral ligament from proximal to distal until the LHB tendon dislocates medial to the bicipital groove. The ablator is then used to cut the LHB tendon distal to the superior labrum and proximal to the 4 o'clock anchor suture limbs. The 2 suture limbs of the 4 o'clock and the 2 suture limbs of the 5 o'clock anchor are pulled sequentially until the 2 double pulley knots and the LHB tendon are pushed towards the anterior glenoid rim through the subscapularis tendon split. The 4 o'clock and 5 o'clock suture limbs are tied. The limbs of suture are shuttled through the remaining anterior glenoid labrum, and additional knots are tied to fix the labrum to the LHB. The final construct with the LHB fixed onlay with 4 knots on the anterior glenoid is checked and tested looking from the anterolateral portal, making sure the biceps tendon works as a sling anterior to the humeral head and has a hammock through the subscapularis tendon split without compromising internal or external rotation. The knots of the Sachs Remplis are then tied.